Let's talk about the management of diabetic ketoacidosis using the two-bag method. The goal of the two-bag method order set is to improve the care that we deliver to our patients by standardizing and streamlining the management of DKA. The order set should cause lower incidences of hypoglycemic events and lead to faster anion gap closure, correction of acidosis, correction of blood glucose, and lead to earlier discontinuation of the insulin infusion. So, a very quick, very basic overview of DKA. DKA occurs when there is a deficiency of insulin, which leads to the breakdown of fats into ketones. Cells need energy to function properly. Normally, glucose is the cell's major source of energy, and insulin plays a major role in getting the glucose from the bloodstream into the cells. In DKA or in an insulin deficiency, there's no way of getting the glucose into the cells, so the cells are starved of energy. Without being able to get into the cells, the glucose then remains in the bloodstream, causing higher blood sugar. If the body cannot convert glucose to energy, it breaks down fats. When the body needs to break down fats for energy, it does so by releasing free fatty acids, leading to metabolized ketones. Those free fatty acids are converted to acetone, the cause of fruity smelling breath in DKA, and beta hydroxybutyric acid. These increased acids cause bicarb to drop and the anion gap to increase. So, simply put, insulin deficiency causes fats to be converted to energy. When fats are converted to energy, ketones are produced, which are acidic, causing acidosis. This state leads to osmotic diuresis, which causes dehydration and also electrolyte depletion. Basically, in an attempt to maintain homeostasis, the body dumps water into vascular space to help with kidney filtration. The kidneys are not able to reabsorb all that they filter, so there's increased urination, and potassium and glucose are dumped into the urine. In DKA, there is a lot of fluctuation of potassium, and even when the serum potassium appears normal, the intracellular potassium is often quite low. And we will talk about potassium more later. A DKA diagnosis is made when a patient has a blood glucose of less than 200 milligrams per deciliter, a pH of less than 7.3 or bicarb less than or equal to 15, and ketones in the blood as evidenced by beta hydroxybutyric acid or ketones in the urine found on urinalysis. DKA resolution is achieved when ketosis has stopped. We define DKA resolution here as glucose less than 200 and anion gap less than or equal to 12 or beta hydroxybutyric acid less than 1. The aim is to stop ketosis with administration of insulin, which will stop the overproduction of acid as well as lower the blood sugar. So there will be correction of blood sugar, but correction of blood sugar does not equal DKA resolution. When insulin is given, the glucose will come down, but that doesn't mean that the DKA is over. DKA is not over until we stop the breakdown of fats and stop the ketosis or stop the overacid production, which will normalize our anion gap and get that revolution of beta hydroxybutyric acid. So, yes, DKA treatment will lead to a correction of blood glucose, but our focus of DKA treatment is the normalization of the anion gap and or normalization of beta hydroxybutyric acid. So, a recap. The goal of DKA treatment: stop ketosis, replace potassium, treat hypovolemia. How we intend to accomplish those goals is laid out here in this DKA treatment algorithm. This algorithm may look very busy on first glance, but let's break it down back to the basic components that we just discussed. The goal of treatment is to stop ketosis, replace potassium, treat hypovolemia. How is our DKA protocol going to do that? It's going to give insulin to stop ketosis, potassium to replace potassium, and fluids to fix the hypovolemia. Let's break each of these down even further. Starting with potassium management. When DKA happens, there's an overall potassium deficit in the body. Remember, even if our serum potassium values look normal, with the increased acidosis, as hydrogen ions go into the cells, potassium comes out of the cells. Also, we lose potassium as a good amount gets urinated out, and in addition to this, we start administering insulin that may lower potassium even further. So first step of the DKA protocol before we start any insulin is find out what our potassium level is. If it's less than 3.3, we are not going to give any insulin because it's already have a total body deficit. We don't want insulin to drive that even lower. That could be dangerous. So potassium is less than 3.3. We are going to notify our provider. We are going to administer potassium via the initial potassium order. And once the patient's potassium is greater than 3.3, we can begin the insulin and begin to administer the maintenance potassium, as shown here in this EDH screenshot. The maintenance potassium will run for the duration of the DKA protocol with one exception, which is if the patient's potassium becomes greater than 5, as seen right here, we are going to hold the maintenance potassium and notify the provider. Next is our fluids. We know that for the most part, patients that are in DKA are hypovolemic. The goal is to replace that fluid deficit over 24 hours. To do this, we're starting by giving a bolus of an isotonic crystalloid fluid. As you can see here, it is going to be lactated ringers. So we are giving a bolus of lactated ringers at 20 milliliters per kilogram. There might be certain situations, like in the setting of a significantly reduced ejection fraction or an already fluid overloaded patient, in which the bolus is not clinically indicated. So a provider might modify the bolus based on a specific clinical situation, but for the most part, expect to be starting the whole protocol with an initial bolus of lactated ringers, 20 milliliters per kilogram. And on completion of the bolus, we are going to move to a steady IV fluid administration rate of 250 mLs of fluid delivered via a 2-bag system. In the 2-bag method, we will always have fluids being delivered at 250 mLs per hour. How we get that 250 mLs is dependent on the patient's blood sugar. So in the 2-bag method, we have 2 bags of IV solution hung at once. One bag contains dextrose, the other bag contains no dextrose. This way we can titrate how much dextrose is going into the patient while still maintaining a constant volume repletion with a half normal saline base at 250 mLs per hour. So the rates of each of these bags can be titrated while the overall rate is still that constant 250 mLs per hour. Okay. Let's say a patient's blood sugar is 270. Because that patient's blood sugar falls in this top range here, we know that the patient does not need dextrose-containing fluid. So we would run bag 1, the bag of just half normal saline, at 250 mLs per hour. Bag 2, the dextrose-containing fluid, will be at 0 mLs per hour, and we will have a total of 250 mLs per hour. If the patient's blood sugar is 178, that falls in this range. So we would end up decreasing the bag of half normal saline from 250 mLs per hour to 125 mLs per hour, increasing the bag of half normal saline plus D10 from 0 mLs to 125 mLs per hour, and we would still have that overall amount of IV fluids being delivered at 250 mLs per hour. Let's say the patient's blood sugar dropped to 135. In this case, we would want to increase the dextrose-containing fluid. So we would decrease the rate of the half normal saline bag to 0, increase the rate of the half normal saline plus D10 to 250, and again, we are still at 250 mLs of IV fluid being delivered an hour. So this is what we're going to be seeing in EDH once our bolus is finished and we have started our 2-bag method. So let's say the patient's blood sugar was 270. We are going to run this half normal saline bag at 250 mLs per hour. We are going to hold this dextrose containing bag. Then, should our patient's blood sugar fall into this next range, I think we said it was 178, we would be running both bags at 125 mLs per hour. Then if the patient's blood sugar falls into this below 150 range, I think we said 135, then we are going to hold the half normal saline bag and run the half normal saline plus dextrose bag from up to a rate of 250 mLs per hour. Again, we are giving a constant rate of 250 mLs per hour of fluid, just looking at how much of each bag of either dextrose containing or non-dextrose containing fluids we are giving based off the patient's hourly blood sugar. We need to have that dextrose available so as to not drop the patient's blood sugar too quickly, because our goal is not just to drop blood sugar, it's to stop ketosis and close the anion gap. Okay, so now for insulin. Remember, before we start any insulin, we need to confirm that the potassium is greater than 3.3, and if not, we need to correct the K. Once the potassium is greater than 3.3, we will start our insulin drip. We are essentially going to start the IV insulin at 0.1 units per kilogram per hour, and for the most part, we are just leaving it there. If the glucose does not decrease by at least 50 milligrams per deciliter in the first hour, then we will administer a bolus of 0.1 units per kilogram of insulin, as seen in this linked order right here, and we will just continue the same insulin infusion rate. So the only time we would be giving an insulin bolus would be in that first 1 hour if the glucose level did not decrease by at least 50 milligrams per deciliter. So the insulin rate is going to stay the same until the blood glucose reading is less than 150. So if we get a blood sugar in the 70 to 149 range, we decrease the rate of insulin by 50%. As you can see here, this is only to be done once. So if I get a blood sugar that is 132, I am going to decrease my rate from 0.1 units per kilogram per hour to 0.05 units per kilogram per hour. And then I get another blood sugar, and let's say it's 99. I am going to just maintain my same rate because I have already decreased the rate by 50%. And as you can see here, we are only to do that once for the duration of the drip. This 98 or whatever I said the blood sugar was is still in a normal blood sugar range, so we're not at risk for hypoglycemia. So we know that this is an okay therapeutic rate. We are going to keep going at that same rate. However, if we see a blood sugar that is less than 70, we are going to pause the insulin, as seen here. We are going to recheck the sugar in 20 minutes, and if it is above 70 again, we can restart the insulin at 50% of our current rate. Remember, during this, we are supplementing with dextrose-containing fluid, so the sugar should come up, but also we are treating the hypoglycemia as we normally would. And that is the insulin drip. Every 4 hours, we are going to have to release a BMP order in order to assess the potassium and the anion gap. Once we see a glucose level less than 200 and the anion gap less than or equal to 12, or the beta-hydroxybutyric acid less than 1, we are going to notify our provider, who will begin to transition to subcutaneous basal dose insulin, and 2 hours after the initiation of that long-acting insulin, we are going to notify the provider again, and the DKA order set can be discontinued. These orders here are going to show up in the nursing communication / information orders section of your active orders. So that is DKA management using the 2-bag method order set. Here is that algorithm once more. Hopefully it makes a little more sense now, and you can also find this algorithm listed under the illustrations tab or extended text tab of this skill. Thanks for watching.